this general body meeting is adjourned and we'll reconvene at 4:30 p.m. because of lack of quorum.
Okay. So after having listened to a whole hour of talks about OCT and geography with regard to retinal diseases, we will now sort of look at how it can help in diagnosing and managing glaucoma. Now, the big question has always been, yes, there is intraocular pressure and intraocular spikes. That's one point. The other point is the vascular insufficiency that develops from the raised pressure. But the question is reduced ocular perfusion primary condition or a secondary condition to RGC death? So RNFL thickness, GCC thickness, RGC function, and visual sensitivity and electrophysiology and other metrics are RGC depth-related biomarkers, while ocular perfusion is analyzed using the FA, Doppler flowmetry, speckle flowmetry, Doppler OCT, or MRI. Now, there are limitations with all these methods. Now, OCTA, I'm not going to go into the mechanics of it or the principles behind it. That's been explained very well by the previous speakers. But if you look at it from the glaucoma perspective, we are looking at comparison between normal and pre-perimetric optic nerve images. We start finding areas of capillary dropout as shown by these images. And in this sequence of images, you can actually see the difference between mild, moderate, and severe glaucoma over time and comparison with OCT images and field images progressively. So peripapillary angiography is something that actually shows the difference over time with the box plot images. So normal and glaucomatous eyes have a drop in the number of peripapillary flow density over time. Patient with normal images, you can actually see the fact that there is no capillary non-perfusion. You can see the patient with the wedge defect that shows up as inferior nasal step, and on the peripapillary pictures in the multimodal pictures, you actually see the capillary dropout. Now, advanced glaucoma, of course, this is very challenging because there's such extensive capillary dropout. It's very difficult to say how we quantify this. So over time, how this can actually change, we can also look at inside the disc vessels or also at the level of the macula. And then the OCT regions, OCT actually scans superficial, intermediate, and deep. Fractal analysis is a quantitative method of evaluating the vessel density over time. And this actually allows us to get much more information about spacing between the large vessels, spacing between the small vessels, optic disc, small vessels, and the large vessels as well. It actually generates a contour heat map across the various vascular metrics. And you can also then superimpose or overlay over the optic nerve head with the various regions of the visual field mapping and also the GCC and the RNFL maps as well. And it actually shows quite good correlation across structure, function, and vascularity. Current literature in OCTA and glaucoma, about 100 plus peer-reviewed articles. So what should we be looking for? How good is OCTA as a tool to pick up or evaluate glaucoma? How repeatable or reproducible is it? What's the correlation of the parametrics with established metrics like nerve fiber layer thickness and visual fields? How does it perform across the different types of glaucoma spectrum, and what are the subtypes? So significantly low OCTA parametrics in glaucoma eyes is been seen in comparison with normal eyes. And the diagnostic ability increases with increasing severity of glaucoma. Now that's tricky because we don't need OCTA to identify glaucoma when it's severe. We already know by looking at it clinically. Reproducibility and repeatability have been found to be pretty good. If you look at correlation of parameters with established metrics, significant correlation has been found with visual field mean deviation. Strong OCTA function association has been compared to OCT RNFL function association, and possibly vascular loss might have been a better biomarker than structural changes for the difference, for the decrease in visual function in eyes with glaucoma. In ocular hypertension, it has been found that because of the dysregulation of the blood flow in these eyes, you can actually identify reduced perfusion. Pre-perimetric glaucomas, this might be a good discriminant function to differentiate between pre-perimetric and established glaucoma. The data, of course, is limited in the macula and optic disc area for glaucoma, pre-perimetric and ocular hypertensives. Now, what happens when the disease is advanced? There's a floor effect like you have for OCTA, and that then makes it challenging because in OCTA, though, it seems to be that there's less impact on the floor effect because there is no limitation of the quantification as is there for the nerve fiber layer thickness with the standard OCT RNFL images. NTG showed significant correlation, and so did in-angle closure. However, the sensitivity is fairly better in open-angle glaucoma compared to angle closure glaucoma. So OCTA is non-invasive and objective. Repeatability is fairly good. It's faster and more objective compared to visual fields, and comparable discriminant function to OCT RNFL function. Is it a better tool? Probably with the floor effect not being a challenging factor, it might be a better tool than nerve fiber layer defects. There is, however, a lack of reference standards for evaluating the device because we don't have a normative database to compare it to. Longitudinal studies are required. It is restricted to specific groups of patients. Non-IOP related biomarkers need to be figured out, and we still don't know whether it's cause or effect. That's the answer to this. So it's good probably at this point to monitor progression in moderate and late stage monitoring, and small vessel acquisition is difficult because of the speed of visualization. The dynamic range is still a question. Correlation between structural and functional parameters need to be better established. The flow signal quantification is still a challenge. And if you look at it, do I need to incorporate OCTA in glaucoma practice at this point in time? Not yet, probably. But will I need to do it in the future? You need to rewind back to using the OCT in retina 30 years ago, and we all thought it would just be a fancy tool, and it's not. It's a game-changing tool. So that could happen. Thank you.